Welcome back, everyone. I don't know about you, Janae, but I know that has been some incredible presentations in track one. I'm sure there have been in track two. And today, this is your 2 o'clock session Eastern time, which has a panel discussion. So this is the only track. So you made it. You're here. And we're going to be hearing from Dr. Schefler, Dr. Stacey, and Dr. Reichstein today on what's new in ocular melanoma, the standards of care for NCCN guidelines.
I'm super excited to have you guys here with us. So thank you for being here. Thank you, Bree, for all the work you've done in track one. So let me go ahead and we're going to start introducing our speakers here. First up, we have Dr. Andrew Stacey. Dr. Andrew Stacey runs the Ocular Oncology Service at the University of Washington in Seattle, Washington. His clinical practice is focused solely on eye cancer in adults and children. He completed his residency in ophthalmology at Kellogg Eye Center at the University of Michigan, and he followed that by completing a fellowship in the Eye Cancer Center at Mooresfield Eye Hospital in London, England.
That's right. And then Dr. Schefler is a renowned researcher in eye cancer and has published over 80 peer-reviewed publications, 20 book chapters, and given over 90 national and international meeting presentations. So she's going to be really fantastic today. And she serves as a reviewer for 20 major ophthalmic journals. She participates in all the major currently enrolling multi-center clinical trials in eye cancer in the U.S., including AURA, COOG2, or COOG2, as I've heard, trials in radiation retinopathy, and trials in retinoblastoma.
And finally, Dr. Reichstein is a graduate of the world's premier ocular oncology fellowship at Wills Eye Hospital. Under the direction of Drs. Jerry and Carol Shields, Dr. Reichstein's interests include the diagnosis and management of patients with all types of ophthalmic tumors. I know. My goodness. You're right. We've been doing so good. It's like we're little medical journals and we're just, yeah, it's catching up to us. So he has been working with patients in all types of ophthalmic tumors, including uveal melanoma or nevus, retinoblastoma, vitreoretinal and choroidal lymphoma, vascular tumors of the posterior segment, and choroidal metastases. We're very excited to hear from these three clinicians and physicians. So let's go ahead and welcome them to the stage.
Coming up, Dr. Andrew Stacey.
Hi, everybody. Thank you so much for that introduction. I'm excited to be here as well, and it's nice to see some familiar faces here in the chat also. I'm excited to be here with these two other doctors. We're going to talk a little bit about some of the new things in uveal melanoma, and I'm going to start with my slides here. Yeah, thank you. So we're going to talk a little bit about the NCCN guidelines, and really one thing in particular that I'm going to point out here that has kind of been changing over the last few years. So the NCCN guidelines are guidelines produced by a group of doctors, oncologists, ocular oncologists, radiation oncologists, who get together and try to determine what the best data and the best research information is, so that they can come up with standard guidelines for the treatment of different diseases. And when they did it for uveal melanoma, how do let's see, I've got to figure out how to get through my slides here. Does that switch? I believe it does. Yes. Okay. So what I wanted to focus on today was just briefly for 10 minutes or so on what it means to be high risk. So there's a number of ways that you can determine if a choroidal melanoma is high risk. There's really two main categories, and I'm going to talk about some of the scientific terminology, including some gene names, but I don't want you to be too concerned about that. I just want you to be able to see them so that when I show the slide with all of the NCCN guidelines, you'll recognize what those names look like and why they are there. There are two main ways to determine if a tumor is high risk or not. One way is through molecular testing, and one way is through clinical staging. And we're going to talk about both of those and how they relate to each other. Clinical staging, there are a few ways to do it, but the NCCN guidelines and most of ocular oncology has moved to adopting and using the American Joint Committee on Cancer Cancer Staging Manual, or the AJCC. This is what most tumors refer to as the TNM staging. TNM stands for 3 separate categories that are used to stage or give a prognosis for a tumor. The T stands for tumor category, the N stands for node or lymph node category, and the M stands for metastasis category. I want to talk today just about the T stage and the T category. That refers to the tumor. When we're talking about the tumor, there are 4 different variables that are important to us when we're trying to determine how risky a tumor is in its ability to spread or to metastasize. Those 4 categories are the thickness of the tumor, the diameter of the tumor, whether the ciliary body is involved. The ciliary body, as many of you know, is one small organ inside of the eye that's hidden behind the iris. And we know that melanomas that involve the ciliary body are higher risk for spread. And then the 4th category is whether or not the tumor has grown through the sclera, or what we call extrascleral extension. So if the tumor has grown through the wall of the eye, that is what the sclera is. Usually tumors stay inside of the eye wall, but they can occasionally grow outside the wall of the eye, and we know that that's higher risk as well. So we use these 4 different points of interest to determine how risky a tumor is. And you can see here we have 3 different tumors that are all very different risk. Here is a very small melanoma that is right in the center of the eye. Its thickness is going to be very, very small. Its diameter is going to be very, very small. This is going to be what we call a T1, or the first category. T1 is the lowest. On the other side, on the right side of the slide, we have a very large melanoma that's taking up a very big portion of the inside of the eye, maybe a third of the area of the inside of the eye. This tumor is most likely going to be a T4 tumor because it is so large and because of its location, which is probably in the ciliary body as well. Here in the middle, we have a medium-sized tumor, and this could be somewhere in the middle, a T2 or a T3, based on different size characteristics of the tumor. We know that T1 tumors, like the one on the left, they metastasize or spread less often than T4 tumors, like the one on the right. That is the clinical staging. So let's talk briefly about the molecular staging. So molecular meaning that we're looking at the molecules inside of the tumor cells. There are a few molecules that we can look at inside of the tumor cells that can help us figure out if the tumor cell is high risk or low risk in its ability to spread. The 3 that I want to highlight here are DNA, RNA, and the chromosomes inside of the cell. So if we looked at the DNA, we could look at specific genes inside the cells of the tumor. And we know that certain changes in those genes, or what we call mutations, certain mutations in those genes can either help or hurt. Sometimes a mutation is helpful, meaning that the risk of spread is lower. Sometimes a mutation is hurtful, meaning the risk of spread is higher. Here you see 3 mutations that we know well. The first mutation on the top there is a mutation that is probably protective. And if a cell has that mutation, it probably has a lower risk of spread. Whereas the one on the bottom that many of you may have heard of, the BAP1 mutation, the BAP1 mutation, if it's within the cell, probably indicates that the cell has, or the tumor has, a higher risk of spread. So this is how we look at DNA. How we look at RNA is through something called a gene expression profile. This is a very common test. Many of you have probably heard of it. A gene expression profile allows us to look at what the DNA is doing, or what types of downfield progression from the changes within the DNA we are seeing in the RNA. And when we do an RNA test, like the gene expression profile, we get different output. We get what's called class 1, and we break class 1 into 2 separate categories, class 1A, class 1B, and class 2. We know that patients with class 1A tumors have a lower risk of spread. Class 1B tumors have an intermediate risk of spread, and class 2 tumors have a higher risk of spread. We also know that there are some other interesting things that we are looking for in these gene expression profiles. Many of you see a PRAME response coming out in some of the recent gene expression profile studies, and the jury is still out on what exactly that means. Perhaps we'll hear more about that today. Another thing that we can do is look at the actual chromosomes. So this is all of the DNA bound up together. And there are some chromosome changes. These are bigger changes within the big collection of DNA. We know that some tumors have lost big portions of their chromosome. In fact, if you have loss of chromosome 3, or in other words, what we call monosomy 3, that's an indication that it may be high risk that the tumor will spread. Same if you have a gain or extra DNA inside the long arm of chromosome 8. These are what people call cytogenetic studies. So how do we get all of this information? This information has to be obtained through a biopsy of the tumor. And without a biopsy of the tumor, you could not have the molecular staging. So molecular staging is not required. You can have clinical staging alone. But the one thing I wanted to mention is what to do with these 2 bits of information when you have them together. So now that we've gone over this, you can read the NCCN guidelines and know exactly what's going on. So this is high-level stuff, but we just talked about each of it. So they list here the things that are high, that indicate that a tumor is low risk, the things that indicate that a tumor is medium risk, and the things that indicate that a tumor is high risk. You can see in the low risk category, a class 1A result, that's from the gene expression profile. A disomy 3, or in other words, normal chromosome 3, is also low risk. A gain of chromosome 6p, this is another alteration within the chromosome that is protective. The EIF1AX mutation is protective, like we talked about. And then the tumor staging, if it's T1, it's protective, meaning low risk of spread. Within the intermediate risk, we have the class 1B from the gene expression profile, SF3B1 mutation, which again is a DNA study from a biopsy, or whether the tumor is stage 2, T2 or T3 based on the AJCC results. And the high risk is the other thing. So a class 2 gene expression profile, loss of chromosome 3, or what we call monosomy 3, gain of the short arm of chromosome 8, that's what 8q means, a BAP1 mutation within the tumor, PRAME expression, we know now to be concerning. How concerning? I think we will learn more in the coming year or so, and a T4 result in the tumor. So this is all very interesting. The thing that begs a further question is, what do you do if the 2 results, if you get a clinical prognosis and a molecular prognosis that don't match? So what if you have a small tumor that's T1 in the cancer staging, but class 2 in the gene expression profile? This absolutely happens. What if you have a large tumor that's stage 3 or 4 from your AJCC staging, but the biopsy result comes back as disomy 3, or in other words, normal chromosome 3, or class 1A in the gene expression profile? I will tell you that at our institution, less than half of the patients have what we call concordance in the prognostic information. In other words, high-risk molecular features are not always high-risk clinical features. Low-risk clinical features are not always low-risk molecular features. And what the guidelines currently don't lay out for us is how exactly to use all of this information. It's all new information and we're all learning. There are a number of ways to combine the information. The important thing is not the specific way to combine it, but the important thing is that we use all the information available to us. So sometimes we can't obtain a biopsy, and that's fine. Or sometimes your doctor may not want to obtain a biopsy for various reasons, and that's fine. And we can use the clinical information. But if you have two sets of information that are discordant, usually what's going to happen is there's going to be a discussion with the oncologists who are deciding how often to scan the body or how often to do surveillance into the future. And they will use both of those informations to figure out how often things need to be done. So if in our practice, if we had a small melanoma or a T1 melanoma that came back as class 2 on a gene expression profile, we're probably going to be scanning that patient a little more frequently than we would if it came back as a class 1A and was also a small tumor. But I just wanted to lay out for you the prognostic information that's ever changing. Thank you so much for allowing me to be here. It's a moving target as we learn more about different prognostic tests each month. And it's kind of an exciting time to be part of the field of uveal melanoma because we're getting a lot more diagnostics. So thank you very much.
Okay, and we're going to hand it off over to Dr. Schefler. And if Dr. Schefler, if you can pull up your slides, that we have those ready to go if you have them. There we go.
Can you guys see them?
We should be good. Take it away.
Okay, terrific. All right, well, that was an absolutely terrific overview, Dr. Stacey. That was amazing. I'm going to actually kind of eliminate some of the slides I have because your talk was so terrific and thorough. And I certainly don't want to repeat anything that you said. I have just kind of a grab bag of 3 different things that I kind of would consider kind of hot developments at the moment that I thought, our patients here in the audience today would want to hear more about. So I would say kind of the hottest, and I'll just kind of quickly cover those 3 topics. I would say the hottest development, I'd say, of the month, which I'm sure many of you know already, is that there's a new drug called tebentafusp, hard to pronounce, nicknamed by many in our community Tebi, because it's just easier to say, which was developed by a company called Immunocore, which is a brand new treatment for metastatic uveal melanoma, which is slated to be approved by the FDA in around February of 2022. And as everyone knows, this is a very big deal because there are no FDA-approved therapies on the market currently for metastatic disease. And so this is a very exciting thing for us and for our patients, for our whole community. The paper in which their phase 3 data was established was published 2 weeks ago in the New England Journal of Medicine, which many of you may know is essentially the most prestigious clinical medical journal, certainly in the US, if not in the world. So I thought this was exciting, not only because the data is meaningful, but because it was a kind of a reminder that if you do meaningful work, even in our little tiny field, you can get lots of attention. And that's good for our patients because we need as much visibility as possible. And what the paper showed was that there was increased overall survival for the patients who were in the Tebi group compared to what was called investigator choice. And I'll show you what that means in a minute. And this is very exciting, obviously, for our patients who have metastatic disease who are eligible for this therapy. And, what the company will be doing over the next year is rolling this medication out and figuring out which of our patients are eligible and how to kind of get this medication to as many of our patients as possible. And then they're with an eye toward the next step, which will be actually trying to figure out whether this drug might be useful in what's called an adjuvant setting, which means giving it to patients who do not yet have metastatic disease, but have high-risk features like the ones that Dr. Stacey talked about, where we're worried that a patient may develop metastatic disease later. So these are just a couple of little cartoons that were in that New England Journal of Medicine paper that was published a couple of weeks ago, just to kind of explain how this drug and how the trial worked. So Tebi is what's called a biallelic molecule. It's like a 2-part molecule that combines a T cell receptor with an anti-CD3 effector, and basically is able to bind to cells that express GP100 and S100, which are basically markers for uveal melanoma. And so the way my melanoma medical oncologist likes to explain this to patients is that this drug is like a dating service. It brings antibodies to uveal melanoma cells so that they can be suppressed. And the way the trial worked is that it was what's called a 3-to-1 distribution. So there were 3 times as many patients in the treatment group as in these sort of control groups, so to speak. And the control group wasn't a bunch of patients who received nothing. They received what's called investigator choice, meaning that the medical oncologists were able to choose whatever drug they felt was kind of their standard of care. Of course, we don't really have a standard of care. And the majority of the patients in that group received pembrolizumab, which is a kind of standard immunotherapy drug that's used, that's FDA approved for many other cancers, and has been used for uveal melanoma kind of off-label for some time. And so this was the kind of most important slide in terms of the data that was developed over the trial. And what you can see is that here in this yellow line at the top, the patients who received the tebentafusp, their likelihood of surviving, their probability of overall survival, and that's on the y-axis, was higher at all time points along the trial after 3 months than the control group. And this, obviously there's many statisticians who do, crank out lots of numbers behind the scenes on these trials that showed that difference was statistically significant. There was also a difference in what's called progression-free survival, meaning that the tumors didn't grow on imaging, although that was less so. The interesting thing about this trial is that patients were given the medication as inpatients for the first 3 doses, and that was because they had a lot of fever and skin rashes that were related to the mechanism of the drug, but there were no treatment-related deaths. And in fact, the amount of these reactions that patients had was actually associated statistically with having a better response. So it's actually almost like having a side effect was a good thing. And so essentially this drug did demonstrate a higher survival in patients who got it compared to standard of care, which was pretty exciting. What was what led to the company submitting for FDA approval. Only about 50% of the population actually is eligible for this drug because there's a certain what's called HLA type or subtype, genetic subtype that has to be met for patients to be able to receive this. And so one of the things that many of you will be hearing from your melanoma medical oncologists locally in your community is that if you're a patient who's high risk, who your medical oncologist is concerned about, they will test you for what's called the HLA-0201 subtype to see if you may be eligible for this drug down the road. So in terms of the NCCN guidelines, Dr. Stacey did such a good job talking about this. I don't think I'll go over it at length, but essentially, just as he said, the NCCN is a committee of melanoma medical oncologists and general oncologists and just 1 or 2 ocular oncologists who kind of talk about different guidelines for how, what standards should be used to determine how patients are treated. And there's some controversy about this, as there are with many things in small fields. But essentially, they lay out charts like this explaining how patients should be worked up and based on tumor size and other factors, what their treatment should be. And they look at these risk factors, as Dr. Stacey talked about, related to DNA testing, RNA testing, in AGCC classifications, and then make guidelines, recommendations for treatment and imaging based on that. One thing I would say is that what you can see when you look at their graphs is that their guidelines are often written in a quite vague way. So, for example, for high-risk patients, that is patients who have class 2 disease, or as Dr. Stacey said, chromosomal changes or mutations in important driver genes like BAP1, what the guidelines recommend is to, quote, consider surveillance imaging about every 3 to 6 months for 5 years. And so you can see it's written pretty vaguely. And one of the things that, we certainly deal with in boots on the ground, day-to-day challenges, and I know many, if not all, the patients on the call know this, is that constant back and forth fighting with insurance companies to get them to approve this imaging, in part because these guidelines are written so vaguely. And one of the things that we and many others have been really pushing for is to try to convince the folks on the NCCN network to kind of write these in a much more rigid way so that insurance companies are not able to weasel out of their responsibility for surveillance imaging as much as they try to. And one of the very exciting things about TEBI, I think, is that once we have an actual FDA-approved therapy for metastatic disease, it's going to be much more difficult for insurance companies to deny these scans because we actually have a therapy to offer to patients once they develop metastatic disease. And I'll go ahead and skip over that because Dr. Stacey covered it. And then the very last thing I want to talk about briefly that I think is hot is treatments for radiation retinopathy. As many of you who've undergone brachytherapy yourself know, one of the major kind of devastating thing that happens to the eye after you've undergone radiation is vision loss from the kind of side effects of having strong radiation applied to the sensitive tissues of the eye. And this is just kind of a, colorful, dramatic picture of a patient who has radiation optic neuropathy and radiation retinopathy after having a plaque. So everything you see here is really abnormal. All these hemorrhages, all these cholesterol crystals, there's fluid here under the retina and within the tissue of the optic nerve. And this is an eye that's angry that it received radiation. So I started doing trials for radiation retinopathy almost 6 years ago here in Texas. And started with a trial called the RRR study, or triple R radiation retinopathy study, in which we used a medicine called ranibizumab, which is actually FDA approved for many other retinal diseases. And we did it in conjunction with our colleagues in Dallas at Texas Retina Associates. And we took 40 patients and randomized them to different treatments for radiation retinopathy so that we could try to see what the effect of this drug was and whether it would help slow down the vision loss that patients experience from undergoing radiation. And so this is just a real quick graph showing what happened to our patients in the study. The red bar is the patients who received this medicine every single month. And what essentially happened was, here's where their vision started at the beginning of the study. And at the end of the first year, their vision had actually statistically improved by about 4 letters on the reading chart, the chart that you get your vision checked every time you go to see us. And that was very statistically significant compared to the natural history of this disease. And then the second year of the trial, where we actually decreased the frequency at which patients received the drug, their vision went pretty much back down to baseline. And so this was very helpful information in terms of understanding, okay, this drug is useful. You do have to give it quite frequently to see an effect, and you probably have to maintain it for at least 2 years. And we went on to do other studies looking at this drug. Sorry, let me fast forward through these cartoons, including a study called the ART study, which will be published shortly, looking at a drug called Eylea for this condition. This is just an example, a cartoon of one patient with an OCT, which many of you have probably seen. So a really, really swollen retina that after 1 year of therapy with this drug looked, pretty flat and squeegeed out of all that, terrible edema, which makes the vision really bad. And we've seen some very nice successes with this drug. And there's a very large national network called the DRCR, or Diabetic Clinical Research Network, that's actually in the process of funding a brand new radiation retinopathy trial, which will be nationwide and include many, many of the centers across the country, trying to finally do this on a very large scale to establish a treatment standard for patients. So thank you all so much for your attention. And hopefully that was informative. And I will pass it back to David. Stop share.
Thank you so much, Dr.
Did that work?
So now we are going to have Dr. Reichstein. Oh, my table. Take me down. Take me down. Sorry.
I'm not sure what just happened, but I wanted to thank you guys so much for having all of us. Thanks to Andrew and to Amy for those really informative.
Thank you for being here. I will just let you take it away.
Yeah. And thanks so much for those really informative presentations from both Andrew and from Amy. It's really an honor to be part of this. I wanted to start taking some of the questions that have popped up online, and then move into a hot topic of my own, which I think really applies to all of us, and that's. But first, a question from Kevin O'Neill: what can we as OM patients say to ocular surgical oncologists who routinely offer and rely only chromosomal analysis? And the answer is, you can always just ask for another biopsy to be taken, but I wouldn't say that chromosomal analysis is bad in any way. here in our practice, we tend to use GEP testing just because we have a relationship that's set up with Castle and has been very easy to move into that. But chromosomal analysis often tells us the exact same information that GEP analysis would. It just comes from a slightly different form. And I think, a medical oncologist who's going to take over your care really ought to be able to take either one of those pieces of information and use that to come up with really what is the appropriate way to monitor and stage you, and then how to come up with a regimen for watching you in the future. So if that's a source of anxiety, I would say that you've probably gotten really excellent care up until this point, because really it's two sides of the same coin. And then from Sherry Agriati, which class is isodiazomy 3? So diazomy 3 usually indicates that you are heterozygous for what's called the BAP1 mutation. The BAP1 mutation, the BAP1 gene is seen on chromosome 3, and was really one of our first identifying genes that gives us an idea of bad prognosis. So oftentimes patients who are class 2 will also be monosomy 3 when you look at both GEP analysis and chromosomal analysis, so it probably would be a class 1A or a class 1B tumor if you're in a diazomy 3 mutation. But on the topic of really being afraid about these things, and Kevin, I appreciate the way that you worded this by saying that you have a personal daily fear of metastasis. Let's talk about the fear of cancer, which in uveal melanoma has been really kind of an avoided topic. And I would say one of the things that has just started to be looked at is the importance of identifying yourself as a patient who has cancer. This topic called benefit finding, where you can simply say to yourself that this may be a challenge that you're going to accept and overcome, and in so doing, you have the ability to have a much more positive outlook about how you're going to do later on, and you're going to avoid for yourself the depression and some of the anxiety that comes with a diagnosis of cancer. And this is one of the things that I think we've lagged behind in as ocular oncologists and medical oncologists who treat melanoma, just because this kind of work has been done for a long time in cancers that are that are more common. But I think that the importance of simply talking it out in the way that you guys have already demonstrated that you're interested in doing, this identifying yourself as a cancer patient, but as someone who has the potential to survive, is really going to help you out and helps us out as providers, and make our quality of lives and your quality of lives a lot better. And I would point a lot of you to the work that's being done by Tara McCannell and other groups in the Department of Psychology, especially at the University of California, Los Angeles, if you're interested in that kind of thing. For my own part, what I've done, and I've shared this with all of you in the links on my bio, is I've compiled questions that I get from a lot of my patients. And I give them a handout, really, a pamphlet on how I see and how I like to talk about and think about uveal melanoma. And being able to read that, have the patients come back to me with that, really, I think, starts engaging people in the diagnosis. And what we're seeing is that there's actual proof that sort of engagement can help the quality of life of a cancer patient moving forward. Those were all the prepared statements that I had, and I know that Amy and Andrew wanted to have a chance to answer some of the questions as well, and I think we can open it up now.
Can you guys hear me?
Yes, we can hear you guys. So if we have any other questions that have come up, Stacey, Dr. Stacey or Dr. Schefler, did you guys see any specific questions that Dr. Reichstein already addressed that you would like to also chip in on?
Sure. Yeah, there was just one little thing I wanted to add. I think one of the patients was asking about isodisomy 3. So isodisomy is a kind of an unusual situation where one of the copies of chromosome 3 is lost, and the remaining faulty copy actually duplicates itself. And clinically, functionally, we understand now that that's essentially the same as monosomy 3, and so that's a poor prognostic sign. And actually, one of the criticism of NCCN is that isodisomy is not included in that chart, and that may be why you were asking. So I think functionally it's worth thinking about that as if it were a class 2 result. And so that's we would identify that as a patient who's high risk.
So I do have a question, just as a patient,
Sure.
what can we do as far as those I'm going to say it wrong, the NCCN, the NC and those guidelines that you
Right.
shared at the beginning,
Right.
Dr. Stacey. What can we do as patients to, I guess, self-advocate for wanting those to change?
Oh, that's such a good question. I mean, I think patient engagement and involvement in these things is so important. I don't know the answer to that, but it's a terrific question. Certainly, a lot of us have been working hard to kind of get those tweaked in a way that'll be beneficial for patients, particularly from the insurance standpoint. I don't know. I'd have to get back to you. I don't know if David or Andrew have good ideas about that. I'm not sure, but certainly it couldn't hurt. It's a really good thought. And also on the chat, it looks like someone named Erica Barrett shared the link for everyone of how you can see those NCCN guidelines. You have to, and she's absolutely right, you have to register on their site. But once you kind of go through the whole registration process, you actually have access to all their documents. It's totally free and public. They just want to be able to send you emails. So just in case all the patients want to see
You
them.
always want to be able to send emails. That's how
Right.
it goes.
Right. And there's some other questions from patients there. Andrew, do you want to take some of this?
Sure. Yeah. It looks like somebody posted a link to the NCCN guidelines. They are public, and I believe in that link they show the list of 30 or 40 individuals who are making the guidelines. If you happen to be at a place where one of those people is, it would be, I'm sure, welcome to have input from patients on these things. I know that at my institution there's a number of individuals on that committee who would be happy to hear feedback on these things.
I guess the one thing I would add on that is that one of the criticisms has been that relative to the number of people in the committee, there's a very small number of ocular oncologists.
We all agree with that.
Yeah, we agree with that.
Right. And I think they're both people who are actually not full-time ocular oncologists. So one way maybe for patients to advocate would be, as Dr. Stacey said, to sort of contact people on that list and say, hey, we feel there should be more ocular oncology representation.
Yeah.
That's a good point.
And I'll just, a generic response to, there are a number of questions here about what to do if you haven't had a biopsy. Can you have a biopsy after radiation? These are all things that can be done sometimes. How useful they are is debatable. And, the gene expression profile is a very hot topic right now. And I do use it, but I would agree that it is not a requirement. A chromosomal analysis would be fine, a DNA analysis would be fine, or just a clinical stage is also adequate. There are situations where we don't biopsy, and that's fine, and we have the information from the clinical diagnosis or the clinical staging only. Biopsy is not without risk, and it is not a perfect solution. So I was talking about the data in our center. We have our own research coming out looking at these things, and there are many ways to get to the information about risk and prognosis, and a gene expression profile is not the only one, though I use it a lot. It is not the only one. So if you haven't gotten one, it's not the end of the world. It's okay. You can be screened without one. I mean, that would be the only question, right? It would change your screening currently. It may change things in the future, but currently it would change your screening. So I think you can get to that information in a few ways.
I would know if there's a question, are there options for those who would like to have a biopsy done after radiation? And that's something that's currently being studied right now. Is tumor tissue viable for GEP testing or for chromosomal analysis after it's already been radiated? And that was something that was sort of thought to not be the case for a long time. Turns out that there may be opportunities for biopsy to be taken after radiation still that may show viable tumor tissue. And I think more to come on that. So if you've been radiated before, or even if you've had your even if you've had your eye enucleated, there's the possibility of having tumor tissue taken on that specimen and sent for GEP analysis. That's sort of still kind of upcoming.
I mean, the one thing I would say about that though is that the GEP test is not CLIA approved for radiation treated tissue, and that data is really not been done on a large scale way, and verified up to kind of scientific standards. So I think if you've been treated and you get rebiopsied after the fact, you have to take whatever results you get with a very big grain of salt. It's not the same thing as the data, the strength of the data we have for tumors that have not been treated yet. And nucleate specimens are a different story because many centers will fresh freeze tissue in which the DNA and RNA is very well preserved and untouched and has not been affected by radiation. And that tissue was actually used in all of the the kind of studies that were done to establish the efficacy of GEP to begin with. So that that's certainly considered very valid. But radiated tissue is really another story, and jury's still out. So if you send tissue like that to Castle or other labs for a result, they will send you back a result, but you have to interpret it carefully, and it may not be reliably.
I'd like to, if we have time, just talk about Rob Spence's question here, which I think is a very good one. Is HLA germline testing becoming more common as a standard of care? It's important. We're all very excited about TEBI and about this New England Journal of Medicine article, and that we have a treatment that's working, but it's important to recognize that it will not be available to everybody, and it will only be available to a certain subset of patients who have certain findings in their blood, and that's what this HLA germline test question is referring to. Mr. Spence, this is certainly something that we discuss at our institution frequently. We have not made germline testing a standard of care yet, but we certainly have a low threshold to obtain it for higher risk patients or for patients where TEBI might be available in the future. I wonder what the other doctors are doing. Are you guys having standard HLA testing yet, or is just ad hoc?
We haven't yet. Certainly, if a patient is interested in it, we can make it happen. But we have not. We haven't done it as standard of care yet. We're still waiting for the ultimate approval for TEBI, probably before some of those things happen.
So it sounds like basically this FDA approval needs to happen first before some of these things can move forward. we can make some hopeful guesses as to what will happen, but we still have to kind of wait for that to happen.
Yeah, I mean, I think that's the important first step. And I think the data certainly is very compelling, but just like any other new medication, it needs to go through the standards that we would want it to in order to be approved.
That makes sense. We did have a question from Gretchen Evans. Where could we receive that handout? And I know, Dr. Reichstein, you mentioned the handout in your speaker notes. And if we can, we're going to try and pull it up on the screen. Bree is working on that. But if she's not able to, I'm going to walk you guys through on your phones. So you go to the Socio app. You're going to see over here the speaker tile in the top right-hand corner. You're going to scroll down through the names. And once you see Dr. Reichstein, he is the third from the bottom. And you're going to see his biography pop up. Looks like this. All right, it looks like we have it ready to go, but you scroll down from here and you're going to see these options. The top one is going to show you his retina brochure digital document. And then there's also a TNR oncology book. So Bree is showing us here on the screen how you can access this from a desktop. It's very similar to your phone. Again, you're going to scroll down and then you're going to see the Tennessee Retina brochure and the oncology books. And you can click on these and you'll be able to see them pull up on your screen, whether your phone or your desktop computer, so that you can download those and save those for reference or for just kind of having on hand. Give us a moment. It's loading. I know for my phone, it looks like this. Sorry. We're just swapping all over the place here. So it gives you some different options to scroll through and to read through there. So that is definitely some helpful information. If you guys have any other questions about how to find that, don't hesitate to ask. So you can see right here, this is one of the, Dr. Reichstein, is this the one that you were referencing or is there a different one?
There's a different one. And if there's difficulty finding it on the bio.
Oh, okay. I see at the bottom. Are they the flyers that are PDFs or are they the links at the bottom?
They should be links at the bottom.
Okay.
But you know what? We can make this a lot more streamlined over the course of the week if it seems like people are interested in that.
Yeah, for sure. And I think if you guys are just interested as a whole, just make sure to reach out and we will get those added in somewhere that is more accessible. But just know that they are in the Socio app. You just have to scroll to the very bottom. All right. Well, I don't see any other questions from the panel in here or for the panel in here. Do you guys have anything else that you wanted to add? Just a final goodbye for the last minute or two? I
saw one other question from Nancy Beery about another question about TEBI. The answers to some of these questions will make themselves very obvious, I think, once TEBI is actually approved, and a lot of these specific questions can be handled very easily through medical oncologists who are going to feel comfortable doing that. And those are, if you have any trouble finding medical oncologists who are going to be willing to administer that medication, certainly reach out through this group and we can refer you to those people.
Wonderful. Well, thank you. Dr. Stacey and Dr. Schefler, thank you so much for being here as well.
Thank you. It's been a real pleasure. Thank you for having me.
Thanks, guys.
Thank you, guys. Have a good, wonderful day.